Welcome to Recovery Inspired Hope. I am so excited today. We have Dr. Merrill Norton, who is an addiction counselor emeritus who specializes in addiction pharmacology. Yes.
Oh yeah.
Big words for me. But he's here to explain to us, after doing my last video and being at Alliance, I had so many questions. And I know if I had so many questions, having the background that I do in recovery education, I know that you guys have a ton of questions too. So, Dr. Merrill Norton, would you explain to us how opiates specifically affect the brain and the body?
Well, if you understand, and there's a dilemma when it comes to opiates and opioids, in that opiates and the opioids that most people are familiar with are used in pain management. And if you look at pain management, which I'm one of the areas of specialty that I have, pain management has to do with the brain system involved with the endorphins. And now we found out recently the dynorphins. These are the natural bodies. They're sets of enzymes that slow pain messages down from your peripheral nervous system to the central nervous system or the brain in order for it to give you the warning, the pain warning, that something is wrong. And when people have injuries or falls or whatever, substance P is a chemical that's triggered and you feel pain, and then you'll do something about it. And that's what it's about. So what happens in most cases is that if you break your arm or bust a tooth or do something like that, there's a pain message. You go to the doctor or the dentist or whatever it may be, and they go to treat it. They'll set the arm, but they'll also give you most likely a pain management drug. They try to give you non-steroidals, non-opioid based for first, but some pains are more serious than others. So they give you an addition. And what that does, and that's what most people don't know, opioids supplements the natural body's endorphin, dynorphin system in order to reduce your pain. Opiates and opioids do not create confusion. They don't create a lot of sedation. Most people can take them and work. And that's why we give them to them, because you can manage a broken arm and go to work or go to school or do whatever. But in the brain, what it's doing is supplementing what is already there. And so you want to give a pain management drug a very short period of time, because it's like any other neurochemical. If you take it longer than 7 to 10 days, it builds, the body says, well, if you're going to take it from the outside, I'm going to stop producing the natural endorphin on the inside. And that means you increase the amount of drug that you take from the outside. You create tolerance. And so the brain adjusts, and it's very sensitive. So that's one part of it. The other part about opioids and medications, it affects dopamine, which dopamine in the midbrain region creates euphoria. So it makes people feel good. And so there's a side effect. Basically, it's a side effect that you not only have no pain, but also you can feel good. Now, some people, because of the way genetically they're wired, we believe, instead of feeling good, they will feel nauseous. They will feel upset stomach. They'll get over sedated. Again, another adverse drug effect. So simply put, what opioids do is they supplement the brain's natural endorphin, dynorphin system, but as a side effect, they will affect the brain's natural dopamine system that can create several different side effects, some being euphoric, some being nausea and vomiting, those types of things. So we're taking a replacement supplement to help the brain manage our chronic, our situation short term. That's what it's as simply as I can put it.
Mm-hmm. So do opiates affect someone, say like someone like me who has substance use disorder, and then a person who maybe doesn't have that brain chemical makeup? Do pain medications affect us the same?
No. Genetics shows us that some people's endorphin system is deficient from birth. And so when you take, let's say you take a hydrocodone,
Mhm.
and a normal dose of hydrocodone is anywhere from 5 milligrams, usually starts out with 5 milligrams 3 times a day. A normal brain will expand and use that and supplement itself and increase and stop pain. Well, with some individuals who have genetic deficiencies, and we are studying those as we speak, that 5 milligrams is not going to do enough to stop the pain. So they have to have a higher dose normally to start with. And so they may go to a 7.5 milligram, and that may do fine. But also their tolerance curve is much faster than the normal brain. So what it means is they can exaggerate the dose, an effective dose, very quickly. And unbeknownst to them, what most people do, well, if I can't stop it with one, then guess what? I will take another one, unknowing that they're creating a possible problem down the road. So yes, the brains are different. We're wired differently. We're trying to understand the fish. And when I look at deficiencies, there's lots of chemicals that can be deficient that leads to that issue. But simply put, most people that I see that end up with an opioid use disorder usually have strong family history for four things: addiction, uh, trauma, uh, mental illness, or if there's a history of suicide. And all of those risk factors we know are deficiencies and create deficiencies placed in the brain that can be passed from one generation to the next. So it's more on the line of family history more than anything else, we think.
Mhm. So when people decide that they want to come into a medication assisted treatment program, we call it recovery with a side of medication. Um, there's so much stigma with the medication because people will say you're just substituting one for the other. Will you help us kind of stomp out that stigma with the facts today?
Well, if people understood chronic diseases, um, people with diabetics have medication assisted treatments. People with arthritis have medication assisted treatments. People who develop hypertension or high blood pressure have medication assisted treatments. People who have cancer have medication assisted treatments. Um, I could go down the list of chronic diseases, and they're all the pharmaceutical industry tries to give medications that either supplements deficiencies in neurohormone or neurochemistries, or tries to eliminate the issue that may be deficient that creates the symptom. Medication assisted treatments for opioid use disorders or alcohol use disorders or cocaine use disorders are under the same philosophy. It is a medication treated and developed by scientists in order to create and help eliminate deficiencies that are created in the disease. And when we talk about the brain disease of substance use disorders, they are deficiencies that are created. Some are because of genetics, some are because of trauma, some are because of mental illness, some are caused because of the risk of suicide, some are because of the potency of the drugs themselves. Now, when you start giving a high dose, and there's a thing on HBO called The Crime of the Century, when we talk about OxyContin and the high potencies of OxyContin, when you've got an OxyContin, when it first came out, that was 160 milligram, was equivalent to 32 Percodan tablets in one tablet.
Wow.
Pharmaceutical industry said it more is better, and in pain management, the absolutely opposite is true, less is better.
Mhm.
And so people unfortunately took advice of some bad medical direction and ended up with an opioid use disorder. So let me tell you, and I don't have any judgment of that. Now, I've got people out here, then they're looking at people shooting heroin and doing all things. Well, we got people out here drinking and using benzodiazepines. We are a chemical culture. We, as a culture, believe that these chemicals and people use sometimes and develop substance use disorders. Well, that's not for me to decide. That's for the individual to decide. And unfortunately, we have millions of those individuals. So when you look at the opioid use disorder treatment, and you go into a medication assisted treatment program, an OTP.
Mm-hmm.
The OTP medications are to do a couple of things. They are, one, to stop the withdrawal that can lead to potential overdose and death. We have had 81,000 overdose deaths in the last 12 months in this year. 81,000. If we look at the total number from 1999, when we started looking at it, we have had over 850,000 individuals die from opioid overdoses.
Mm-hmm.
And we look at the pandemic, and that's been terrible. We've only had 600,000 people die from that. You understand? But there's no, stigma attached to pandemic or COVID-19 versus if it's a substance use disorder. And the problem is getting people to understand that inside of OTP programs, they are stepped down. They are 6 levels of care that are required by the federal government based on the individual need of the patient. So what I tell people is what you're doing when you go to an OTP is going to go and help with the professionals in there, going to help you stabilize a deficient endorphin system. And if you do that appropriately, you have to, depending on the length of time and the types of potency of opioids, some will have to come out on a minimum dose of an opioid treatment medication. Some may choose to move into an abstinence-based treatment, and some will have a dilemma of being both because of mental illness and other things. So I wanted people to know it's another application of medications used in a chronic disease state that are required to prevent. My philosophy when I train professionals and all of my students is I want to make sure that person lives to tomorrow. Mm-hmm. And I don't care what it takes for me to do. I don't care if it's cancer or diabetes or blood pressure or stroke or whatever. I've had to treat them all. The thing about it is if a medication is available and it's going to keep them from overdosing or keep them increasing their tolerance curve, I am definitely an advocate to do that. So that's what I tell people. It's only medication used to stabilize a deficient endorphin system in their brain. And hopefully we can get them to a point that you can step off or step down and be functional and go out and work and pay your taxes and be with your children. Right. That's what we're after. And unfortunately, we have such stigma in this country, not only with substance use disorder, but mental illness. Yeah. And I fought that fight for 30 plus years, and I continue to fight it. And that's what we have in this interview, is to tell people there are professionals out here that understand that, and they're more than happy to address that with you in the appropriate treatment modality. And that's what OTP is about.
Yes. Thank you so much. Well, that has been so helpful. Thank you for your time here and for all of your answers. So can I just ask you, what would you tell someone that is, trying to come into this OTP program, but might be scared? What would you directly tell that person?
Well, I would tell them, listen, I'm dealing with, in my personal situation, of a woman who has terminal cancer. And I have seen in those clinics hundreds of patients who are scared. But there's really not only one alternative. You need to step through that doorway in order to get appropriate treatment. Now, if you don't get appropriate treatment, then the fear of getting worse or dying is a reality every day. Versus, and so I would encourage them to walk through that door and sit down and talk with someone in the program, such as you had in the program that you had recently, and discuss that with them about what it really is. A lot of people have an opinion about what OTP is, and they have no clue because they've never done the homework and really found out what it is. Just like with any other medical treatment, surgeries, or anything, I would say go and inquire and find out what it is so that you can make an educated decision about what you want to do about your health. And that's a big deal. It's a big deal.
Awesome. Thank you so much. Thank you for your time and for all of your knowledge. And we will see you guys next time on Recovery Inspired Hope.